afternoon. I welcome you all to this webinar on understanding the rising need to prevent hospital-acquired infections, brought to you by Pfizer in association with ET HealthWorld. KNOW AMR is an initiative by Pfizer aimed at addressing the growing problem of antimicrobial resistance. This initiative focuses on raising awareness, promoting research, and implementing strategies to combat antimicrobial resistance and preserve the effectiveness of antimicrobial treatments. As the world moves beyond the emergency of COVID-19 pandemic, the surging rates of hospital-acquired infections have been on the rise. Hospital-acquired infections prevention is essential to creating safer communities, as this is adding to the ever-rising burden of antimicrobial resistance. The lack of infection control practices in ICUs makes patients prone to infections, leading critical issue of hospital-acquired infections and prevent antimicrobial resistance from becoming a global threat across human, animal, plant, food, and environmental sectors. My name is Prabhat, and I will be moderating this session today. Today, we have with us Dr. Palepu B. Gopal, Senior Consultant and Critical Care Medicine, Citizen Speciality Hospital, Hyderabad. Dr. Yatin Mehta, Chairman, Institute of Critical Care and Anaesthesiology, Medanta. Dr. V. Ramasubramanian, Senior Consultant, Infectious Disease, Apollo Hospital, and Dr. Swaminathan, Director, Infectious Disease, Gleneagles, Global Hospitals. At any point during the discussion, before we begin, the audience can share the questions in the chat box, and we will try and answer as many questions as possible towards the end of the session. To begin with, my first question would be for Dr. Swaminathan. What is the burden of HAIs that the nation is currently facing, and what is its impact on patients, and why should we take it seriously?
Unfortunately, we do not have any very good quality data on a national level in terms of the burden of HAI. We do know that this is ever increasing, so much so that this has become an emergency across the world. And unfortunately, it is disproportionately higher in countries where infection control measures are poorer. And therefore, the burden is probably much higher in the developing countries because they don't pay enough attention to this and resources are not put into this basket. And therefore, we do struggle a significant amount with hospital-acquired infections. And the recent pandemic with COVID was a very good example to help us understand that even in spite of us taking a lot of infection control measures, there was actually a significant attributable mortality due to hospital-acquired infections. And it has highlighted to us that multiple pathogens are a problem in different parts of the country, and it is very different in every hospital. It is in fact different in various units of the hospital, and therefore it needs a more in-depth study and understanding for us to take this forward.
Thank you so much for that. Dr. Mehta, if you could add to this, please.
Yeah, see, Dr. Swaminathan has correctly pointed it out that hospital-acquired infections kill a huge number of patients. In fact, we have published studies. I was one of the authors, INIC, which is collects from the developing countries the data. And we have a huge number of patients who were involved in this, 43 countries. And we found that the ventilator-associated pneumonia, which is the pneumonia when a patient is put on a ventilator, was 24 times more than what is reported in the American literature, CDC data. Also, in that particular study, we found that the bloodstream infection was 12 times more than what is found in the Western countries. So on one hand, we have huge number of big problems, huge number of patients who get from the hospital-acquired infections, but also we'll come probably later during the discussion, and Dr. Swaminathan and Dr. Rama both have interacted with me on multiple occasions about the antimicrobial resistance, which makes it worse than what one would expect just from the numbers of the extent of the problem. So we have huge infection rate, not only in hospital acquired, in the community also, and also we have antimicrobial resistance. So the length of stay increases, the mortality increases, and everyone suffers because of that. So forget about the public health issues. I mean, we have so much of contamination of your food and water, and we have resistant bugs in the community. So that is also increasing problem.
Thank you so much for that, Dr. Mehta. Dr. Subramanian, coming back to you, you said that there is not enough data on HAIs. So is there some work in progress on this? Or
There have been attempts. Let's not, I mean, maybe I should not have made a blanket statement saying there is no data. There is data, but is it truly representative is the bigger question. See, Dr. Yatin Mehta has pointed out a very good database, the INIC database, which is actually very, very useful. It gives us a benchmark and a standard of what is happening in the community. There have been more efforts like that. For example, there was this ICU candidemia study looking at fungal infections in the ICU. So what we have noticed is that fungal infections, candida infections in our country happens much earlier than in the Western world. And it is much, much higher than anywhere else in the world. So there is lots of data which is multi-center, basically where both public hospitals and private sector hospitals have combined together to pool their data and to come up with kind of meaningful data. But again, if you look at the length and breadth of the country and the size of the country and the number of hospitals that we have, there is not enough representation from various parts of the country. A lot of the data comes from the south and the west. From the north, some centers like Delhi have a lot of data coming out. But again, from the east, the center of India, the heartland of India, we don't have enough data coming through. The second part is also that we don't have very good data coming from smaller centers. Again, a lot of the data comes from very big hospitals, which have the ability to track these numbers, measure these numbers in an attempt to improve their, their benchmarks. Dr. Mehta is talking about what they do in Medanta, which I think is amazing. A lot of us are trying to see how we can work with this and try and improve the situation. But many places do not have the bandwidth, the manpower, or the know-how to even measure this. And therefore, the input of data into databases is also poorer. And therefore, I think we are still struggling because we need more systematic data being made available from various parts of the country. And for that, I think we need a more robust effort. Possibly the government can help with all of these things. And unless we see those kind of data segments coming through, we can't really make huge generalizations. The patterns are very clear. But to know exactly how big a problem we have, we need those kind of data sets.
Do you have any suggestions here in this context? Would you like to suggest how it could be implemented or some protocols that could be followed?
Absolutely. So I think, a model for public-private partnership is what I would think is worthwhile, simply because a lot of the healthcare in our country does happen in the private sector. But we can't ignore the public sector as well. So getting all the data from the private sector does not reflect what's happening in the country. We need a more mixture of private sector and public sector. We need a mixture of tertiary care, primary care, secondary care, all kinds of levels. We need mixtures of where we do a lot of work, like OBGYN and pediatric work and all that. Where is the data from obstetric care? Where is the data from gynecology care? So we need a mixture of all of these things to come into the mix. And we also need a lot of regional representation. It cannot be from only the big cities. It has to be a mix of all of these things. So it has to be designed that way. And we start collecting data. It is likely to be more representative. And we should have measures to reward people who involve themselves in this, because it's a lot of hard work and it's a lot of extra work on their end. So we need to have some kind of tangible benefits that come out of it so that they can be recognized for the work they put in, so that more people are enthused in joining this project, so that the database becomes more robust.
Thank you so much for that insight, Dr. Swaminathan. Moving on to Dr. Ramasubramanian. Dr. Ramasubramanian, my question for you is, what are the challenges in implementing a robust infection control program in a healthcare setting? And what are the short-term and long-term action points required to overcome this?
Yeah. Thank you for the invitation today. Yes, and that's a very, very practical question which we face. The implementation of infection control is mandatory in all hospitals. You take any accreditation process, whether it is the Joint Commission International, whether the National Accreditation Board, they all insist as a mandatory requirement an infection control program in every hospital, be it a 2-bed hospital or a 1,000-bed hospital. You need to have in place a documented infection control program. But the problem is, as usual, the questions which are asked is, when you set in a written program which mandates a formation of a team, which formates a periodic meeting, there is an interaction between all specialties, including the medical specialties, the surgical specialties, the housekeeping, the nursing division, the sterilization and disinfection, including, monitoring how you use single-use devices. The question asked is, what is the return on investment? Especially when you're working in a corporate hospital, when you're going to invest in putting in place an infection control program which costs money, the challenges would be how do you account that if I'm going to pay, say, 5 lakhs a year on this, what does it show at the end of all this? And that is what is very difficult to convince people in most hospitals. What is the result? We know that it has been shown by studies in the West that putting an infection control team and making sure there is an infection control nurse or a professional for every 100 beds gives a significant savings. This is in a public system where the patients, the healthcare delivery is different. The government pays for the system, but in a private hospital where patients pay from their pocket, the patients pay for their antibiotics, the patient pay for their surgery, the bed. It is very difficult to show that by putting in an infection control system in place, you are saving money for the hospital. It just doesn't make economic sense. So this is the main challenge, ensuring that people understand the importance of infection control and how it impacts on outcomes, better quality of health delivery, all that to make sure that people who are doing it understand is what the main challenge is.
Moving on to Dr. Gopal. Dr. Gopal, I have the same question for you. What are the challenges in implementing a robust infection control program in a healthcare setting? And what are the short-term and long-term action points required to overcome this? I would want your views on this.
Thank you very much, Mr. Prabhat, for involving me in this discussion and this very important question that we're discussing. As Ramasubramanian very elegantly put it, the collection and implementation of hospital-acquired infection data is largely voluntary. Nobody forces any hospital to go for NABH or JCI, and unless they go for it, they won't have a program, neither would they report it. So in my viewpoint, at some level from the government side, hospital-acquired infection control programs and antimicrobial stewardship programs should be made regulatory, not voluntary. At some level, you may start with basic level and you may slowly grow. Now we come to the question of the limitations. Basically, it's in the mind, there are two elements to it. The first element is the vision of the management of the hospital. How do you want to manage your hospital? Do you want to keep it clean, infection-free, get a good name, and get more bed space by discharging patients early? That's where your return of investment lies. You get more bed space, more beds per year, more patients in, more business. The second thing is infection control program is very resource heavy. Resource from manpower point of view, from data point of view, from laboratory point of view, and from training point of view, because infection control program just can't be on a paper, it has to be implemented. That means all personnel, including myself, have to be regularly educated and trained, and training is going to be resource heavy. You have to invest into it and expect return on investment, as Subramanian says, in a different way, not directly. Then of course there's the third aspect, which is punitive aspect. We don't know, both in public and private sector, whether the data of the hospital-acquired infection control programs is in public domain or not. If it is, we don't know whether it's genuine or not. So again, a regulatory approach has to come in where this data has to be put in public domain, which reflects on your reputation, your outcomes, and your business. That is where again your return of investment is, both in a regulatory and punitive manner. Third one is a positive approach, reward. For the hospitals which do good on this program, for the personnel which do good on this program, there should be a rewarding process. We can discuss about rewards a bit later. Reward doesn't necessarily mean monetary. They may be non-monetary also.
So, Dr. Gopal, you mentioned that this is very resource intensive as well.
Yes.
And it is voluntary and not mandatory. But if patients acquire infections in a healthcare setting, their stays are prolonged.
Yes.
So that they recover from it. So in the end, the patient suffers.
Absolutely.
So how can we overcome this?
Again, by implementing your program in a sincere way, in a transparent way. And of course, there has to be some partnership with the patient and patient family as well. The strategies we can discuss as we go down with our colleague experts later. But unless the hospital has a genuine intention and a vision you cannot reduce this. It cannot be just an NABH exercise. It has to be daily routine process of the hospital. Just like cleaning your ward, you have to clean your hands also. And that there start the whole program. Patients, there was some approach in USA where insurance companies refused to pay for the complication coming from hospital-acquired infections. Such approach will bring a genuine pressure on all stakeholders in this process.
So you're saying if insurance companies void the insurance, as in they say this is null and void because you have acquired an infection in a healthcare setting.
They're already doing so in some US hospitals.
Dr. Ramasubramanian, your view on this?
Yeah, absolutely. As I said, when you look at things in India, if the patient stays an extra 10 days, the hospital gets more money paid because the patient pays for it. Unless, as Gopal said, that in the US, the insurance will say, no, this is an infection acquired in the hospital. The hospital is responsible for an infection control program, which has not been in place properly. We will not pay. Only if such kind of punitive measures come in, people will wake up to the fact. Otherwise, as long as the patient is paying, the hospital is happy making money. This seems a little callous, but at the end of the day, every hospital is for-profit organization, and it is very difficult to ensure. Maybe in the long run, the reputation of the hospital will be damaged. But when a situation is present where administrators run the hospital and doctors work in hospitals, this is going to be very difficult because the administrators look only at the balance sheet. So these are things which have to be addressed holistically to make things better.
See, I'd like to. Yeah.
Yes, absolutely. I was coming to you, Dr. Mehta.
See,
please.
I would disagree with both Michael, because if the insurance companies stop reimbursing for any hospital-acquired infections, we all are going to be out of business. And the first people who will be out of business would be the public hospitals. The government hospitals, several studies have shown the incidence of hospital-acquired infections is many times more than in private hospitals. So, healthcare services in India, then it would be restricted to the primary health centers. All tertiary care hospitals would be shut down. You cannot do that. Yes, punitive in a different manner is okay. I mean, you should have some data on the public domain that Apollo Hospital has less infection than my hospital or vice versa. Those sort of things are okay, but you cannot have where the insurance company will be laughing to the bank and all the doctors would be out of business for no problem, no issue because of them. Because there are multiple issues which are involved in the hospital-acquired infections, beginning from the periphery to the tertiary care hospital. So we need to, as Ram rightly pointed out, we have to resolve it holistically. And obviously we need more data for that. Data can be made mandatory in at least some way, because see, COVID, what happened? Every COVID which was positive was reported to the government, which was mandatory. You had to do it. Now, you can analyze the reasons why a patient got infected and all, which we do at our place. Every case is analyzed and we put it to the infection control committee. But yes, we have to give more teeth to the infection control committees. We have to have more robust antimicrobial stewardship programs in every hospital. And we have to start beginning from that. See, ICMR did publish the data of antimicrobial resistance in 2021, which was a very useful data. But this thing has to be taken very seriously, and cutting down the source of finance is not the way to go about it. I mean, don't kill the goose which lays the egg. I mean, you must find out why the goose is infected. So that is how we need to go about it. I mean, government should also prioritize this problem, because starting from the poultry farms where they feed cholesterol to the fowl, I mean, to the sewage, to the water, quality of water. I mean, so I think we need to treat it holistically, and not only that, the government. Different ministries should not work in silos. They should have a central body which works together, coordinating every activity. That means the chemical fertilizer, the agriculture ministry, the health ministry, everything will have to work together. So that is how it is.
So I have a question here. You mentioned that if this happens, if insurance companies stop paying out, then public hospitals will go out of business first. So are you saying, or are you suggesting that public hospitals do not follow or adhere to protocols in infection control compared to private hospitals, or they are short-staffed?
No, short staff or adequately staffed is only one of the issues. That is not the sole reason why hospital-acquired infection is higher, A, in India, and B, in public hospitals. Yes, staff is only one thing. Training is another thing. How much of infrastructure is there for the patient care? I mean, where you have, there's so many other factors which come into play. Staffing is not the only thing. Motivation is another thing. Incentive is another thing. Disincentive is another thing, which doesn't happen in public hospitals. Nobody can fire somebody, some nurse who refuses to wash her hands and has a high incidence in that particular area. Nothing will happen to her. While at least in private hospital, we may be able to take some action. So that is the point.
Thank you so much for that, Dr. Mehta. Dr. Ramasubramanian, yes, you wanted to add something to this.
Yeah, I think I probably didn't make myself very clear. What I meant was that we shouldn't, one of the ways in which the US is handling it is by putting in punitive action to ensure that hospitals prevent infections. But that is not the way. You know, each country has to devise its own ways to do it. What I meant is that every hospital should have an infection control program, should have policies in place, should have audits in place to ensure that all these are being adhered to. We cannot come to a zero hospital infection collection data system, because in spite of the best efforts, we are now in a situation where we are being more aggressive with treatment. We are putting more lines, more tubes, more catheters, which directly bypass the defense system. We are immune suppressing our patients through medications. We are doing transplant surgeries. We are doing post-transplant immunosuppression with medicines. We are involving cancer treatment with drugs which are far more immune suppressive than before. So in this situation, I don't think hospital infection rate can be made zero, but I'm saying that if you have a system in place, if we have a policy in place, that is what should be audited and looked to.
Dr. Swaminathan, you wanted to add something to this?
Absolutely. No, I think the point is very clear. See, all of us seem to think that HAIs is a very simple thing and it's a single entity. It's actually not. The problem is this: what an infection control person measures and what a clinician is measuring are different things. Like when we say from an infection control point of view, we call it CLABSI. From a clinician, they call it CRBSI. So what is pneumonia for a clinician and what is pneumonia for an infection control personnel in terms of ventilator associated pneumonia are not the same. Therefore, please understand, it's not so simple saying it's like this, it's like that. I mean, on the top of it, it looks like that. It's not, number one. Number two, taking punitive actions based on these kind of classifications will only drive the whole thing underground. And that's exactly what has happened in the US, because they made the infection control guidelines, the terminology different. Now, suddenly it looks like a lot of things have gone away. They haven't gone away. It's just that they don't meet those guidelines. I honestly believe that you should look at the 2023 CMMS guidelines on reporting of quality outcomes from various hospitals, and they made it mandatory. So, for example, if somebody is admitted with pneumonia, somebody is admitted with a stroke, or somebody has a knee replacement or a hip replacement, they want all hospitals to report 30-day outcomes, 30-day mortality, 60-day outcomes, and 90-day outcomes, and things like that. Not for everything, but for certain benchmark things. I think that is a better outcome, and to show that, my hospital has 90-day outcomes of this much. See, I think patients would all be interested in that as well. See, if you have an option of going to 10 different hospitals, and if all 10 hospitals are publicizing this and they are mandated by the government to do so, then the customer has the choice of choosing which one he wants to go to based on outcomes. I personally prefer that rather than a punitive action, because the problem is that, it's very difficult to define a fault or an error, because even the measurement itself is an issue.
Thank you so much for that, Dr. Swaminathan. Dr. Gopal,
Yeah.
you wanted to add something?
Yeah, I just wanted to reinforce what Dr. Swaminathan is saying. I was saying earlier also, right now we're at a voluntary level, starting with a minimum basis. If you make it mandatory and transparent, mandatory reporting and transparent domain, if you keep it, I think that will be a lot of positive pressure on the whole healthcare community to take care of this aspect.
I think Dr. Mehta did add that, like during COVID, everybody was sharing the data and utilizing it. So a similar concept and guidelines, if they were implemented, it could reduce the burden of HAIs and AMR in itself.
In this particular aspect, if we let the WHO programs percolate down to institutional levels across the government of India, for example, we have this One Earth concept and the GLASS program, which is a surveillance program coming in. We have to let that percolate down the stream, and that will automatically generate a lot of data, which will be very useful to everyone.
Thank you so much for that, Dr. Gopal. Moving on, Dr. Mehta, what can be some of the best practices that need to be adhered to in healthcare delivery to prevent HAIs?
See, I think as pointed out by my other colleagues, that you should have a robust infection control committee and program with teeth in every institution. And that should not be only restricted to private or tertiary care hospitals, that should be also extending to public hospitals. Because health is important for everybody. If the poor guy is admitted to a government hospital, he should not be subjected to a higher infection rate just because of callousness or lack of resources, because there are enough resources. We know that the government has enough resources. So I think we have to have an infection control program which is active and with teeth. Also, you have a data collection, which we already discussed, because only when you have data, you can compare the several institutions or several systems of functioning, of how the hospital acquired infection is, and what it was last year, and what it is next year, or what was the last month, and what is it this month. I mean, you would know what is, and you go into root cause analysis of every sort of case which happens, serious infection, particularly in the ICU, what happens. Besides that, you have to provide enough physical support. I mean, staffing has already been raised by you. I think there should be adequate staffing. There are guidelines laid down again in the ICU, how much staffing you require for ventilated patients, for non-ventilated patients, and so on. Also, I think surveillance. I mean, it is important to isolate the patients, contact precautions and all. These things are not followed in many public hospitals and poorly followed in smaller hospitals. So I think the same yardstick should apply to a tertiary care JCI accredited or NABH accredited hospital to a non-JCI accredited hospital. I think because the outcome is similar. If the infection happens in the hospital, the stay increases, the morbidity increases, the mortality increases. That affects all of us equally, and ultimately the society and the government or whatever individual has to pay for it, the family has to pay for it. So I think we have to take this seriously. Also, I think starting from the periphery, where the unnecessary antibiotics are also prescribed, chemists are prescribing medicines, people take Augmentin or whatever they, I should cross the counter, they purchase it, they have a sore throat, they have viral throat, and they will take antibiotics. So this has to be stopped, because we all travel abroad quite frequently. There is no antibiotic you can buy across the thing in a chemist shop. You cannot. You have to find a doctor who will examine you and then prescribe. So I think this needs to be made a little more stringent. Other thing is, also quickly I will mention that the quality of antimicrobials also has to be regulated more stringently. You cannot have hundreds of companies which are, I don't know what sort of environment they manufacture the antibiotics. So you buy salt from China and then you dissolve it into distilled water and you make it to vials or injections, ampules, and sell it wherever. I mean, this has to be controlled a bit better. You have to have a stringent quality control regarding people who are able to sell, manufacture and sell their antibiotic microbials in the market, because we do not have standardization. That is one problem in this country. And so that has to be regulated by whichever ministry it comes under. So this will lead to proper quality of antimicrobials. This will lead to reduced unnecessary usage of antimicrobials. Antimicrobial resistance will come down. And obviously your hospital-acquired infection will come down with all these things put together.
Dr. Gopal, how can the shortage of nurses be addressed as a shortage of staff and a challenging work environment that can lead to HAIs?
I think that's one of the most vital factors in the process of running any hospital, including infection control. And this is a universal problem. Though on face of it, in third world countries, it looked like nursing is an unattractive profession, monetarily speaking, from the packages point of view. While it is not so in advanced countries, even they face nursing shortages. So we have to analyze non-monetary reasons for nursing attrition. The most important thing that looks to me after working in our country for a couple of decades is non-empowerment of the nursing professional. the nursing professionals most of the times are demotivated. They don't feel that we are giving them respect or we are listening to their inputs, and they don't feel like stakeholders in this process. So, and they don't feel that they're getting rewarded for their hard work also. Process like infection control are extra burden on nursing program, but it's undeniable that it is a nurse driven process. Infection control implementation, monitoring, data collection, data sharing with the infection control committee, and so on and so forth is fundamentally a nurse driven program where it is directed by physicians. In this process, if we don't give some amount of reward, empowerment to the nurses, they don't feel inclined to do this job sincerely. They also need self-respect. They need a standing in the society that they're contributing to the welfare of the healthcare system. Excuse me if I give you an example. If there would have been a senior infection control nurse in this very seminar, it would have added a lot of respect to the nursing community and data and knowledge to all of us. So this kind of approach, both from medical colleagues, management, and the stakeholder, that is patient, will definitely give more importance to nurses and make them stay back and contribute productively to the not only infection control program, but the whole process of healthcare in hospitals. There is an interesting point here. Right now, many state governments and central government are paying higher wages to nurses than private sector. That leaves a huge thought process to be thought when private sector manage healthcare management, whether they should do something there. I do understand, giving the burden of the largest professional community of the health sector, that the nursing sector, it gives a huge monetary burden on the management. But at the same time, it is the disparity between the paycheck that an Indian nurse receives to a Western nurse is staggering. So we need to think in that direction too. If you put in these few, and then communication, the last thing is communication. Many of the nurses, especially the younger nurses, both male and female nurses, don't feel that they're able to communicate with the leadership, their own leadership, and the management of the hospital regarding their problems, regarding positive inputs, etc. So these are a few of my thoughts and suggestions to both private and public sector to make nurses stay back in their jobs, or non-nursing people look up to nursing as a lucrative profession.
Thank you so much for that, Dr.
Thank you.
Gopal. Moving on, Dr. Ramasubramanian, considering the current threat of HAIs, is there a further need for investing in R&D for newer antimicrobials to tackle multi-drug resistant infections? And what is the current scenario?
Yeah, let me start with the basics. Resistance has certain principles. Resistance is inevitable. And usually the resistance, which means that the bacteria becomes tolerant to the antibiotic, and the bacteria multiplies in spite of the antibiotic, is what is called resistance, is usually happens when the bacteria is exposed to the antibiotic. Resistance starts at a lower rate and progressively increases to a higher rate. It declines probably with time, and sometimes it does not go at all. And the resistance can be transmitted from one bacteria to another. And most importantly, if you're using an antibiotic on one person, this has impact on the entire community. So all these principles have to be kept in mind, that resistance is something which we have to live with. And the only way we can ensure that we minimize it is by using antibiotics prudently. So the first step in how to ensure that we still save our antibiotics for future generations is to make sure that there are guidelines based on which we use the antibiotics judiciously so that we preserve them. Now, moving on, since we already have resistance to several antibiotics, how about newer antimicrobials? How about R&D to detect and identify, discover, invent newer molecules? Now, the problem is antibiotics are not economically a viable solution for most pharmaceuticals. You spend billions of dollars coming up with a new antibiotic, you put in place, and then all the infectious disease physicians and critical care physicians like us who are sitting here will say, don't use the antibiotic because we shouldn't let it go waste. We have to preserve it for a situation where it may be needed. So which means that we are trying to, not only us, all the antimicrobial stewardship initiatives say that use antibiotics wisely, use less of them. So the pharmaceutical company is at a loss, unlike a psychiatric drug or a hypertensive drug or an oncological drug, we advise to use it more prudently and more judiciously. Very soon, whatever has come out will develop resistance. And to add to this, there will be other generic manufacturers who will start manufacturing at the end of a few years' time. So putting all of this together, the question of more R&D and more generation, newer molecules is not something which most pharma industry look upon as a good proposition, which means unless we learn to use our current molecules wisely, we definitely need more molecules, we definitely need more R&D, but we need to ensure that systems are in place to use it properly.
Thank you so much for that input, Dr. Ramasubramanian. Moving on, Dr. Swaminathan, what is your take on this?
I think he summarized it very beautifully. See, the problem is, on one hand, we have the Jim O'Neill report, which says by 2050, we're going to have more people dying of drug-resistant infections than, say, cancer or road traffic accidents or whatever it is, or diabetes. And on the other hand, we have a pipeline which is exclusively becoming more and more dry. There's less money going into it simply because it's not remunerative. And the only way to do it is public-private partnerships. So we need to start investing in our research in universities. So a lot of the drugs which are coming out in the US today in various areas, not just infectious disease, is coming out of medical universities, where they have grants to do research work, and they have a huge number of people looking at all of these things. And a lot of it is coming out as partnerships with large universities, where they spin off from companies like Genentech or whatever it is, and they come out with designer molecules. This kind of orphan problem is there not just in infectious disease, but in certain other things like rare neurological disorders. But the problem in infectious disease is obviously very, very big. We have a big problem and nobody wants to get into it. There, the problem is small and nobody wants to get into it. That's the difference. But the problem is, although we are big, we are trying to make it small. So it kind of is counterintuitive to go into this area. So we need to have out-of-the-box thinking. So a lot of people, even within India, are looking at various areas of drug resistance and molecular mechanisms of things like that. The problem is there seems to be a lack of crosstalk between these people. See, for example, veterinary medicine and human medicine, the communication levels are actually very, very abysmal. We know there are a lot of animal-based infections, what we call zoonotic infections like scrub typhus, which have become a big problem in India in the last maybe 10, 20 years. But the veterinarians knew about this even before that. Why did we not talk to them about it? Why did we realize it was going to become a problem? The problem is we don't talk to each other. I think we need to have more discussions between the bench researchers and the primary researchers and people in pharma industry and things like that, so that we can accelerate this process of drug discovery and share the load, so that we don't expect the pharma industry to do all the heavy lifting where the return on investment is very, very poor. See, for them to beat down 1,000 avenues to come up with maybe one molecule is just not on. On the other hand, for an educational institution to do that kind of bench work, they're going to love it, because you're going to put a lot of people doing a lot of work. And for a PhD thesis or for their dissertation, I think it's lovely work for them to do. So I think that's the way to do it. And for that, we need to invest in these kind of institutions, or at least upgrade the ones which I already have, so that we can do this a little better. Because expecting pharma alone to do it, like Dr. Ramasubramanian said, is just not going to happen. And so we might as well be smart about it.
You've given us the example of how universities are receiving grants and developing and doing R&D in the US. How do you think that could be implemented in the Indian scenario?
So let's not think that it's not happening here. A couple of years ago, I was invited by IIT Chennai for an interesting biomedical conference, and they were presenting a lot of the data that they were doing. And in fact, they were doing an amazing cutting edge work on tuberculosis drug resistance. And they were talking about this kind of concept of railway junctions. So they were looking at, say, tuberculosis gene as many different metabolic pathways. And they were also using things like artificial intelligence to try and find out, if I have to block a particular node, if I block that node, I will take out so many different square blocks of that particular bacterial work. And therefore, it is likely to be more effective. See, earlier, how were we finding antibiotics? More like guesswork. We tried a lot of antibiotics and said, okay, maybe this will work, kind of thing. That's a very inefficient way of doing it. Now, the idea is to go back to the bacteria and look at it and say, what will work here? What will work here? When I was in the US, I remember one of the options that I had to work with for my ID fellowship program was somebody who was doing crystal formation in HIV drug resistance. He was picking up drug-resistant mutants from a lot of people and then looking at that particular enzyme, and he was growing crystals. And from the crystal, he was trying to find out how we can tweak the molecules to try and better fit it so that you can overcome the resistance. That's another example of some amazing work that is being done. So a lot of people are doing things like this, and let's not think that it's not happening in India. The problem is, I had no clue that IIT Chennai was doing work like this, and they are just down the road from where I am. I mean, a few kilometers down the road, but nonetheless down the road. So why do we not have any ideas to what is happening in all these beautiful ivory tower institutions? And why is it that we are not having this kind of discussion with them as well? See, Dr. Gopal has said, why have we not invited an infection control nurse? See, even that is an oversight, isn't it? Same thing, I would say on a larger scale, is that we are not involving all the parties who could contribute to this to work together. And I think that requires a larger thinking. You need out-of-the-box thinking, and you need a workforce, a task force on this to look at all the stakeholders to try and see how we can bring them together.
That was very deep and insightful, Dr. Swaminathan. Thank you so much for that. Moving on, Dr. Gopal, this is for you. Considering the current armamentarium of antimicrobials available to treat infections, where do you see the importance of AMS practices and their implementation in healthcare institutions?
In various institutes of our country, taking cue from our Western counterparts, we have upgraded our antimicrobial stewardship programs now. It is an umbrella program right now. It's not simple infection control. It is controlling the utilization of antibiotics, selecting the antibiotics, preparing an antibiogram, preparing a antimicrobial formulary. All these things are being looked into. If these things are again, pardon me for repeating myself, made mandatory rather than voluntary, I think we'll move up the ladder quicker than what we are doing now. Because while the antimicrobial resistance is increasing in 110 proportions, the drug line is not moving in that direction, and we are left without any drug. Not only that, even if a new drug is coming into market, it's hugely expensive and not available to majority of Indian population. Government made a good move recently by capping the cost of some of the higher end antimicrobials, and that made it available to probably higher number of population. But that should not allow us to misutilize the same drug unnecessarily. The same applies to veterinary industry as well. Now we'll have to reorganize our resources in our individual hospitals, look at it, how we can make it more productive, like Swaminathan Subramanian is saying, we have to look at it differently, not simply as utilization and control, but optimization. And I think that is the way forward.
Thank you so much for that, Dr. Gopal. Moving quickly to Dr. Mehta, would you want to add something to this?
No, I would like to add to that development of newer research R&D in India. I would just like to add one point. The Department of Science and Technology should invest some in development of newer antimicrobials, combinations or whatever. So there should be grants available easily for these sort of things. They should encourage it. Also, what I have found is some new antimicrobials have been developed in India, but some of my ID friends are very skeptical because these are Indian antimicrobials. So I would request them who are listening to this, just because they're Indian, that doesn't. Yes, we do require more publications and more RCTs, but yes, let's not be skeptical, because the multinationals are not that much interested in developing antimicrobials against gram-negative infections, which are maybe typical enzymatic methodology to hydrolyze the enzyme. So the resistance development in India is from a different enzymes than what it is in the Western population. So they will not be interested that much in development of NDM, say for instance, something which works against that. So I think we should encourage that, and the minds also should be open as long as the science is robust.
Just one quick question. This is for Dr. Ramasubramanian. How important is education for the judicial use of antimicrobials in the healthcare community? Do we need to focus on early education for medical students?
Absolutely. Absolutely. You cannot say anything stronger than that, because I passed out about close to 35 years ago, and we were taught, we read textbooks, we were taught pharmacology, we were taught about clinical medicine, but nobody taught us how you select your antibiotic, how you use your antibiotic. And it is very sad for me to say that still 35 years later, graduates coming out are still as clueless about handling the common problems which you face in the outpatients or the inpatient department. We are taught esoteric stuff. We are taught about the 25 causes of various conditions. But if you have a patient in front of you with a common cold, how do you approach is still lacking. I'm very happy to see that there are changes in the medical education and curriculum coming up now. And I hope that the role of how a doctor should use an antibiotic, how he selects an antibiotic, the importance of antimicrobial stewardship is all conveyed to him, at least much, much more than what we were exposed to. But yes, unless you start early, I don't think a doctor is going to be sensible in using his antibiotics.
Thank you so much for that. Yes, Dr. Swaminathan, you would want to add something to this.
Absolutely. So, Sir William Osler said that what separates man from other animals is his desire to take medicines. He was wrong. What separates man from other animals is his desire to take antibiotics. No human being goes to a pharmacy and says, give me cancer medicine. I feel like I have some cancer coming along. But everybody goes to the pharmacy and says, give me some antibiotics, right? So that's the problem. So we are pre-programmed to do so. And like Dr. Ramasubramanian said, a couple of years ago, I was involved in a feedback situation for the National Medical Commission in terms of curriculum development. And we highlighted a couple of things. Number one, there is absolutely no training on HIC on AMS in the undergraduate level, whereas in the Western world, it's absolutely mandatory. You could be an orthopedician, you could be a psychiatrist. You will be failed if you don't know enough about HIC. So you have to know HIC. Why is it that our undergraduates know nothing about HIC and AMS? The second thing is, you will always see lectures on how to use this antibiotic, how to treat that disease. Have you ever heard of a lecture on how not to use antibiotics? See, the problem is, if you look at the MCQs that we have even for NEET, it will say, this patient has this disease. What antibiotic do you choose? You are going on saying, reinforcing, consciously and subconsciously saying, give antibiotics, give antibiotics, give antibiotics. Subconsciously, the messaging is very, 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 very powerful. Till we stop doing this BS, it's not going to get better. We have to start telling our students, don't give antibiotics. Don't give antibiotics unnecessarily. Obviously, if it's necessary, it is important. But even our MCQs should start reflecting it. Our questions should start reflecting it. As long as the subconscious messaging is give antibiotics, it's not going to get better.
Thank you so much for that, Dr. Swaminathan. Would Dr. Gopal or Dr. Mehta want to add something to this quickly?
The undergraduate level, there should be emphasized how not to use it, not only how to use it. He's absolutely right about this. And the threat of antimicrobial resistance and misuse and inappropriate use of antibiotics, that all should be emphasized during undergraduate days, because many of these will become general practitioners outside and who are rampantly going to wrongly prescribe antimicrobials, which we see all the time, the prescriptions coming from periphery. So I think that it should be inculcated early into them. And just for Dr. Rama's comment, so Dr. Rama is a child in front of you when he graduated when I did.
Thank you so much for that. Dr. Mehta, yes, Dr. Gopal, you wanted to add something to it.
I just want to add that while all these suggestions about formal education are very, very valuable and vital, there is non-formal education also. Just like when you start working in a hospital or in an annual basis, if all the healthcare workers are forced to relearn this antibiotic stewardship principle, just like do a fire drill in your hospital, this has to attain that level of significance in the learning process, continuing learning process of the healthcare workers.
Thank you so much for that, Dr. Gopal. Now, quickly moving on to the audience questions. The first question that I have for you is antimicrobial resistance of the body because of excessive use of antibiotics is separate from antimicrobial repellent technologies that can be used for non-medicine related applications. So how can we encourage that, and how can startups be involved for joint studies and technology development implementation?
I think my ID colleague should answer that.
Yeah, I'll take this. See, first of all, I think when we refer to antimicrobial resistance, it doesn't mean to the body. It means that the bacteria has developed resistance against an antibiotic. So it's got nothing to do with the body. It's the ability of the antibiotic to survive and multiply in spite of the antibiotic, which earlier used to kill the bacteria. And that is the question. The second thing is, how can we encourage and startups to be involved? I think there should be more platforms, just like we have hackathons, just like we have interaction between IT and others. There should be a platform to encourage the basic researchers, the industry, and the medical professional to identify what their problems are and how the research people can help, in developing solutions for these.
There's another question. What are the approaches to addressing the data gaps identified for AMR? What are the efforts at broadening wastewater surveillance as an epidemiological method? Is the case of HAIs different in scope and dimension than other communicable diseases?
Challenging question. Okay. So there are data gaps identified in AMR. So in the Western world, you look at it in terms of DDDs, meaning how many days of treatment are you giving per person and things like that. So we need to start looking at how we can do this. Unfortunately, in our country, we are manpower restrained in capturing this kind of data. So I think we'll have to start looking at crude numbers in terms of hospital occupancy rate, maybe ICU occupancy rate, and utilization of various key antibiotics. I would start with probably carbapenems like meropenem and look at how their utilization is over the years and try and see if they put into place measures to try and reduce the utilization of the same. So, I mean, it's a complicated area, and I suppose technology and AI could really help us in these areas. What about wastewater surveillance? Actually, COVID showed us really useful data on this. So whenever you have an outbreak kind of situation, wastewater picks it up even before there is a hike in the number of cases in the community. So assessing wastewater is going to be very, very key. A lot of countries across the world have started doing wastewater surveillance for things like polio, to monitor to see if there are wild polio virus strains coming out in that, because that will predict a polio problem and things like that. So a lot of people are doing that. But for AMR, will it specifically help? I've not seen any data specific to AMR. It could be something that could be game changing. Scope and dimension of other than communicable diseases. Well, I don't know, but I suppose we are all limited by our own knowledge at this point of time. Once we start leveraging technology to do different things, you will come up with some interesting ideas. As of right now, I can't think of anything, but if my panelists can think of it, sure.
Thank you so much for that, Dr. Swaminathan. One last quick question. I don't think we have enough time to take any further questions. What are the solutions for general practitioners using higher antibiotics without any culture reports?
I think I answered that offline. I honestly believe that the reason for people using it is fear. And because, there is a lot of concern that if you don't do something and something wrong happens, something bad happens, you're going to be blamed for that. And the other thing is the pressure that if you don't do it, somebody else is going to do it anyway, and you're going to lose the patient. I honestly believe that the antidote to fear is not bravery. That's just a very stupid answer. The antidote to fear is knowledge. Where you have knowledge, fear goes away. So we need to start educating people. I'll give you an example of how this can work. In Thailand, they did an initiative where they said we will start reducing antibiotics in the community for 3 conditions. Diarrheal diseases, simple diarrhea. Second one is simple injuries. And the third one is upper respiratory infections. In the next few years, they brought down drug utilization across the country by in the order of tons. Tons of drugs were used less. And they were able to educate the community physicians and be able to achieve that. It was sustained. Now, obviously, we need to have a grassroots level education program, which starts at all levels, starting from the medical student level. And just telling them that doesn't help. The mentors have to do it. People learn more by people's actions rather than their words. So we need to have mentors who do this and follow through on this and educate them. And with that, we can make a difference, but it takes a lot of hard work.
Thank you so much for that, Dr. Swaminathan. I think we are running out of time, so I think we should conclude this discussion as well. Thank you for joining us today for this exciting and insightful discussion on the rising need to prevent hospital-acquired infections, brought to you by Pfizer as a part of its KNOW AMR initiative in association with ET HealthWorld. I thank the speakers for the valuable insights shared, and to everyone for your time taken to attend this webinar. I wish you all the very best in your AMS efforts. Thank you.